Hi, Doc. How are you?
Hi,
Oh, yeah, I can hear you.
you can hear me? I'm
Yes.
well. How are you?
I'm okay.
Okay. How is the cold taking you?
Hey, kwanza I live where it is manufactured.
So you get it before the rest
Tunajaribu
of
tu.
us. Mm,
Yes, yes, yes.
okay, sawa.
Okay, I think Rev should join before time, but I
Mm-hmm.
have his slides in case of anything. Because we had
Okay,
agreed he will join earlier.
okay, sawa.
Okay.
Hi, we'll just wait.
Okay.
Okay, thank you.
Thank you.
Good evening, everyone. Welcome to today's webinar. We are kindly waiting for Reverend Kiplagat Meli. Please let us know if you can hear me.
I can hear you, Doc.
Okay, Sawa. Thanks. Great. So today's topic is exploring spirituality in children. The spiritual, religious, and existential concerns of children with life-limiting conditions. As we wait for Reverend, maybe we can just open the session by saying that we're all palliative care workers, and we understand the holistic approach to anyone we are giving care to. So today we are concerned with the spiritual needs of children and how they possibly differ from the spiritual needs of adults. From the knowledge I gathered preparing for this, it was important to identify their spiritual needs and what gives them their lives meaning. I'm sure as we wait for Reverend, maybe everybody can think of an experience they've had trying to manage the spiritual needs of a child. So let's give Reverend a few more minutes to join us. Thank you for being patient. Good evening again. I've just been told Reverend is about to join us. I posed a question to everyone to think about maybe your experiences with spirituality in children with life-limiting illness. Maybe if someone wants to share their experience in the chat, or on the other hand, if you have any objectives What do you want to gain from this session? Please put anything on the chat and we can engage each other as we wait. Or if you want to speak, maybe just raise your hand. Share your experiences or what you want to gain from the session.
Uh, Dr. Weremba, I can ask a question. One participant asked while registering, how does one balance the spiritual views of the child against those of the minor if they differ?
That's an interesting question. Balancing the spiritual needs of the child versus their caregiver.
Yes, if they differ.
Okay. That's an interesting question. I see on the chat, Dr. Mwinga is saying we may be overlooking the spiritual needs of children, especially because of communication barriers and ability of the child to express themselves. Doc, as I was researching, just trying to read up on this topic, I came across a study that actually says maybe even 5-year-olds can have an understanding about their spirituality and have questions about their existentiality. But I'm sure we'll learn more about that. So there's a message here that the speaker will be joining us soon. Thank you for your patience. I'm sure we can pose some of these questions to him. Keep them coming. Anybody who's had an experience explaining to a child what spirituality or religion is, or to me, I've been asking myself if they ask themselves what happens after we die. Is there an afterlife? How do you explain that to a child? Anyone with any experience, maybe raise your hand. As we're still thinking and as Reverend is joining us, I'm seeing there's some slides on the screen. Samuel Oraya is asking, how can a child differentiate between spirituality and religion? That's an interesting question, and maybe it even ties back to the other question asked about whether what happens in the case that the child and the caregivers views differ, because maybe the child, through their own experience of death or nearing death, might have formed their own spiritual or religious ideas. Sorry, was someone trying to speak? Okay, I see Eugene Kibwana, I think, is sharing an experience. He says, Daktari, why is God allowing me to be in so much pain? A question that was posed by an 8-year-old with leukemia. How should we go on this question as healthcare workers? That's also a very good question. This is a very interesting topic that's very thought-provoking. So keep the questions coming. Okay, I see we have Reverend in the house. Good evening. We can't hear you, you're muted. You're muted, we can't hear you.
Okay, can you hear me?
Yes, we can hear you now. Thank you.
Thank you.
So good evening to everyone once again. Welcome to this evening's webinar. We are honored to have Reverend Kehpca taking us through today's topic. My name is Dr. Weremba Masiga. I'm a psychiatry registrar, as well as working on an MSc in palliative care. So today's topic is on exploring spirituality in children, the spiritual, religious, and existential concerns of children with life-limiting conditions. As I mentioned, Reverend Kehpca will be taking us through it. A brief summary of Reverend Kehpca's experience. He's a religious and spiritual care chaplain, a counseling psychology practitioner, and life coach. He's equipped with the capacity to offer an interdisciplinary approach to the psychosocial, spiritual aspects of human-centered care in both ecclesial and non-ecclesial settings. He's a licensed Africa Inland Church of Kenya pastor and an ordained minister by the National Association of Christian Ministers in the USA. His areas of study include intercultural engagement of scripture and culture, with a focus on spiritual formation and the integration of spirituality in the development of holistic care leaders and professionals in both ecclesial and non-ecclesial settings. He's attended a number of institutions, including Nessens High School, Moffat College of Bible in Kijabe, Louisiana Baptist University, Fuller Theological Seminary, Dallas International University, George Washington Institute for Spirituality and Health, all in the United States of America, as well as the Carey Theological College in British Columbia, Canada. Welcome, Reverend. We're honored to have you. You're welcome.
Thank you. Thank you all for this opportunity to be your presenter today. Thank you because of the kind introduction. I'm sorry I got late. I've not used Teams before. I am a Zoom guy, and the rest of the social media apps. This is my first time to use the Teams, so I'm sorry for the technical challenges. So apart from the many things that Dr. shared with you, I am also married. And that is me. I work in the hospital as a chaplain, and I thank God because of that. So I want us to begin immediately, unless there is something else that you want me to clarify before we go on. Everybody silent?
Just proceed.
Yeah, you had put the PowerPoint, but I'm not seeing it right now. Okay, our topic today is exploring spirituality, spiritual and religious and existential concerns of children with life-limiting and life-threatening conditions in pediatric palliative care. Let's begin by going to the objectives of the topic or the discussion today. I am just beginning a conversation, which I hope that all of us will continue with it. So let's go to the second slide and see the objectives that I hope we will achieve at the end of this conversation. One, we need to we will define spirituality and religion. Secondly, we will say, what does spirituality mean to a child? We will also understand children's spiritual formation and faith development. We will discuss a few pediatric spiritual needs. We will also describe how to perform a spiritual needs assessment in children. We will also discuss a review of principles of spiritual care and introduce something about contemporary cultural strategies. And I will emphasize all through the significance of having interdisciplinary team in children's palliative care setting, and finally make a palliative plan through a case review. There are a lot, but I've selected a few things for us to know. So I will try to be as fast as possible. I am seeing our time is far much spent. We have used 26 minutes trying to connect. So even though the discussion currently in this country and in many parts of the world is the concern for persons dealing with management and treatment of chronic illness is about the cost. But the aspect of age-appropriate palliative care that should start at diagnosis remains untapped in the care and management of children with life-limiting conditions. So the discussion is always centered around the cost of the management of chronic diseases. But on the professional side, and those of us who are in the medical space, we rarely discuss how can our palliative care be age appropriate, especially now that many people say it is generally agreed that palliative care is something that should start at diagnosis. So we find that our discussion doesn't discuss on how we can tap into this palliative care management of life-limiting conditions. So that is the biggest thing that we need to think as we begin this discussion. Because if we don't think about it, then we will continue having a discussion around the cost instead of thinking of how can we leverage whatever resources that we have so that our palliative care interventions take care of the needs of those who are overwhelmed, those who are abandoned, those who are struggling with social cultural safety in the process of dealing with their palliative, their chronic disease treatment. So therefore, to secure resilient and safe social cultural responses to life-threatening conditions, psychosocial and spiritual care intervention for such children and their families is important. In other words, I'm saying, for us to move away from focusing so much on the cost and leaving people overwhelmed and feeling put down by a lot of social cultural challenges, it is important that we position spiritual care as one of the most important interventions that we can use in taking care of the needs of those that we serve. So they have the next slide. Another thing that we need to think in the introduction is that children's spirituality and the dilemmas that come with its absence are often neglected. Why? Many people fear they cannot understand who God, the children cannot understand who God is in their being and in their becoming. Another aspect that, another dilemma that is causing a lot of challenges that is bringing up the absence of children's spiritual care is cultural factors. Many people have perception of they have a wrong perception about pediatric illness and even the issue of death and cultural competence of medical practitioners. There is a lot of biases built around our thinking about children. We are biased sometimes in our thoughts about children and our belief. Most people think that children do not know what is going on around them. So when they are sick, nobody ever thinks that there is a way of meeting their needs, especially because of our cultures. You know, I remember as a young child, even when I needed to tell people that I'm sick, it was very hard because they would tell me, you are pretending. Nobody, culture was harsh to me. Another challenge that that touches on our perspective is, you know, the Western biomedicine approach is more into the physical aspects, but never think about the holistic aspects of a human being. And the other aspect is also materialism. You know, we live in a materialistic culture. Even our preachers preach more about wealth and health, but never think of how that gospel of wealth and health can be integrated into our medical care so that it is able to speak to the pain and suffering of the children. So in other words, in another sense, what I'm saying is that the dilemma that men and women of Jesus' day had, until to the point that Jesus said, let the children come to me, is the reality that we live in every day. Children are neglected, children are abandoned, nobody ever speaks about them, nobody wants to think about their needs even when they are sick. So that is an aspect that is important. So, and that is why I am an advocate of an integration, an holistic view in handling children who are sick and even elderly people. Therefore, I say that our medical space in Kenya requires incorporating the family and religious belief and also other cultural issues that inform the cultural background of many families. Next slide. Why do I use the word life-limiting conditions? The underlying cosmology that underpins palliative care is that in palliative care, we add quality to life and leave quantity to God. That is, the care should achieve a pain-free time of sickness or time of living with the disease. The doctors, the nurses, and everybody in the disciplinary team should focus on eliminating all the challenges that the patient is going through, be it a child, as we are talking about children today, and leave the issue of the number of days, the number of months, and the number of years the child will live to God. So when I talk of life-limiting or life-threatening, this term, in my view, incorporates four groups of illnesses. One, illnesses that are a threat to life, because although there is a curative intervention that is available, it might not be successful in every case. That is one reason why I'm using that word, that sometimes a medical condition have a curative treatment that is available, but sometimes it is not successful in eliminating the disease. So a very good example is a reversible organ failure or cancer. Most of the time, children with the cancer live with it for a long time. So that is why I'm using this word, life-limiting condition. The second reason why I use this term, life-limiting condition, is that those with which treatment may lengthen life expectancy, but for which no cure is known. So there are those illnesses or diseases which treatment may lengthen the time the person will be on earth, but for which no cure is known. Another aspect of illnesses that we have that pushes me to use the word life-limiting condition is those progressive conditions for which there are no curative options, and the only treatment available is palliative. This is something that one of my teachers taught me. It is something that all of us can think about. The fourth one is those conditions that involve severe neurological disabilities and deterioration that could be rapid and unpredictable, like brain damage. So that is why I use the word life-limiting conditions. So what is spirituality and religion? Spirituality, anybody or anything that gives one meaning in life. This is a multi-religious view. You know, we live in a context right now in this country that we already know that we are 42 tribes or plus. And so we have different cultures, but also we live in a country that religion is growing very fast. We have many religious movements that are coming up. Both in our Christian religion, there are many religious movements that comes out of Christianity. Similarly, when you go to Islam, there are various branches of Islam. So we live in a society that is multi-religious. So anybody or anything that gives one meaning in life, that is what somebody has said is spirituality. And it is said that spirituality can be expressed as a religious relationship with God. It also refers to other things. When somebody put a lot of makes a lot of attachment to nature and goes out into nature to get relief from issues that he's facing. So some people have a religious faith called scientists or something like that. So the environment is key. In fact, where the living room hospital is built, the lady that owned the land was a scientist. Nature was part of was what she worshipped. So that is the reality. I met her personally. I talked with her about faith, but she said she worshipped nature. And so for her, that was a source of spirituality. So religion is another term. Religion is another term. Religion means structured or organized group based on shared beliefs, often provides a system of rites, practices, and rituals. And then there is this lady called Puchaski. She says spirituality, she gives us a global consensus derived definition of spirituality. She says spirituality is a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationship to self, family, and the sacred or significant others. Spirituality is expressed through beliefs, values, tradition, and practices. And then another person says spirituality incorporates elements of religion. It is generally a broader concept. Religion and spirituality are not the same thing, nor are they entirely distinct from one another. I hope everybody is getting me clearly. Am I audible enough? Another aspect,
Yes,
another
yes,
definition.
we can hear you.
Yeah, I can see the you know, the response. Another aspect of spirituality is that in spirituality, the questions are, where do I personally find meaning, connection, and value? In religion, the question are, what is true and what is right? So spirituality in children is defined as the ability to derive personal value and transcended beyond the self through relationship with others. So spirituality in children is centered so much on the significant others. I think when we will be seeing the development of faith in children, you will understand this definition. But for now, let's just understand it as it is the ability to derive personal value and transcended beyond the self through relationship with others. For those who do not appreciate so much the religions that we already have in this country, like Christianity and Islam and the rest, or issues of faith, many people have thought of talking about spirituality without using the language of faith and religion. And so many people have used the word connectedness to refer to spirituality. And for me, I tend to tell them, yes, that is a way of escaping from using the word spirituality. But within the definition of spirituality, connection is an important aspect of spirituality. So I agree with them that connectedness captures the description of spirituality in children. Spirituality is connected to questions about life, identity, such as I'm a good person. Am I a good person? What is the meaning of my suffering? What is my connection to the world around me? Do things happen for a reason? How can I live my life in the best way possible? Next slide. So other people have said also, spirituality describes the inner and the outer relational expression of the feelings that characterize an admitted child. When a child is worried, is curious, is in shock, he or she feels bored, he or she is lonely, when the child needs comfort, attention, or is resigned to the pain and the process of disease, or he or she has fear, needs hope, or has an anticipation of doing better, wants to play, trust, separation, and disappointment. All these involve the aspect of the child desiring to have a connection with the other, with the significant other. And the person who has really written about connectedness is somebody that is called Paul Alister. He's a Christian theologian, and he says there are 4 aspects of connectedness: momentum of connectedness, how fast it, how what pushes the connection, resilience of connectedness. Is this connectedness able to survive when there is challenges? Awareness of connectedness. Is this person able to know that I need the connection? And the evaluative nature of connectedness. Can he do a reflection of his connection with the significant other? And the same discussion of connectedness, I felt that I should have this discussion, especially because of the secularization aspect that is coming so fast into our Kenyan space. And very soon we will be having people discussing this issue of, I don't like the word spiritual, or I don't like the word religious when describing the issues of life-limiting diseases. I don't like to have this conversation around my practice or the medical space that I work in. So I felt that the word connectedness is a single word in all the spirituality discussion that captures an aspect that is needed in the discussion about child care in the process of care during their illnesses. So one way that a child can connect is creating the zone, creating the place for the child to share his or her story, and creating a place through role play where he can get into the space and feel accepted. And that is an important thing. Play and storytelling offer healthcare professionals and assessors the opportunity to discover a child's connectedness. You can easily discover what the child values, this significant or transcendent thing that the child has in his life. Play and storytelling. And you know, in our spiritual life or in our practices in the church, we have imported a lot of art that is foreign. But when you go into our cultures, there is a lot of artistic expression that captures many people. And children who have grown outside the city life or outside our towns. For example, I had a child from Turkana, and I realized when I used the Turkana music that is sung in the contextual way of singing music, it would take a lot of attention to what we were doing. But whenever I took the hymns that are sung in the Western way, even in the Turkana language, the person didn't have a lot of attention focused on what we were doing. So role play and storytelling is an important thing that can help the child be connected. Another aspect is building the zone. Additional competencies needed to connect with a child when using play and storytelling, e.g., hospitality skills, safe to share information, empowering a child to enter a level to choose how or she wants to play, liminality, reflexibility, awareness of how child perceives the assessor, connectedness, fluency, trust, and respect by a child to reveal his ultimate concern. So that is an aspect that I thought I need to add into the conversation of spirituality that is very important. What is the role of religion and spirituality in pediatric palliative care? This psychologist called Viktor Frankl says, wrote in his experience in the Nazi concentration camp, man is not destroyed by suffering, he is destroyed by suffering without meaning. The aspect of meaning in religion and spirituality is important. And what is the solution? We who serve, or even the physicians who serve, should help people find meaning and acceptance in suffering and chronic illness. And this is about engaging deepest questions of life. So religion should help, should be used to help people get the deepest meaning. And this is the challenge that physicians face or doctors face when trying to deal with chronic conditions or life-limiting conditions. The question of meaning and who loves me when I am suffering is big, both to children and everybody, and especially children. So religion establishes an ethical foundation for clinical decision making, provides a set of core beliefs about life and meaning. It empowers against depression and fear, especially when we use art, be it music, be it role play, that are centered on the contextual realities of children, will always help them deal with fear and depression or anxiety and the rest of psychological issues that children face. The next slide, and also the issue of death. Let's jump this. This is about the agreed guidelines of pediatric issues. So this aspect of children of being and becoming, when we think of spirituality in children, many think of their growth or development. And the advantage we get as Christian psychologists is what I call theological anthropology. You know, anthropology, the study of man. And the Bible teaches us about, teaches us on this subject called imago Dei, the image of God, that we bear the image of God. And when we begin from this point, we are able to help our children or people understand who they are before God. The other aspect that is important is the Trinity for us who are Christian. The Godhead, the way they coexist, also helps us in the development of children to know that children thrive better in relationships. The same way the relationship between the Father, the Son, and the Holy Spirit brings in something that is called perichoresis, you know, the aspect of relationship, that the Father sent the Son, and the Son gave opportunity to the Holy Spirit to continue with the work that the Father and the Son were doing on earth. So that relationship between the Son, the Father, the Son, and the Holy Spirit brings in the importance of relationship when dealing with the development of children. The next slide. So everyone, including a child, experiences their unique self more fully when in healthy relationship with God and others. Everything is created by God to be and to become what is and not another. That is why the scripture says we are fearfully and wonderfully made. In fact, it says God was so careful not to make a mistake. So when a child understands the fact that he is God's creature and God has done his work in a way that you cannot get mistakes, apart from the mistakes that we have been cultured into or socialized into, then the child is able to appreciate the fact that he is God's being and is becoming what God wants him to be. I believe that God's intention on individual development is inextricably intertwined with our relations with God and one another. So that is why there is a concept that has come up in Christian psychology that is called reciprocating self and spirituality. The aspect that somebody can respond in relational to the other and achieve and be able to know who he is. Next slide. So when we talk of development of faith and meaning in children, it is always centered around the context. Does he have trusting relationship? Is he able to get choices about faith and what is happening in the world? Can he express gratitude? Can he experience loss, regret, and sorrow? And how does he respond to all those things within that environment? What meaning to children in life? So all that is developed within what I have called, it is shaped by the context of his development. Next slide. So when we think of development of children, I like using two scholars to talk about the development of children. I use Erik Erikson, to bring in the principle. And I use somebody called James Fowler, who is a Christian psychologist, to connect the principle with the staging, and then mention the development issues that happens in a child. So the stage 0 is at birth: trust, mistrust. Basic virtue is hope. So the child is an infant. Trust, courage, hope, and love and are mixed with sense threats of abandonment, inconsistencies, and deprivation. That is that stage. And then the experience of basic trust, and also experiences mutuality in the relationship of the mother, and experiences a sense of autonomy. So I'm not going to go through all this. This is how I have designed the development of children in issues of faith. So you see, faith actually starts from what happens to the child at birth and the environment, yeah? the experience of that stage in the parent, and then in the environment, and then in the neighbors. That is how he develops his faith. And so if the child develops in an environment where he's told about the things of faith, he will experience it through the relationship to others. Next slide. And I think you are going to jump. We are going to jump this. I'm just going to allow you get these slides. So I want us to focus on how to offer spiritual care to children. And what is spiritual care? Spiritual care is an essential component of quality palliative care. Spiritual care services include screening, history taking, and assessment. And all this is performed on admission and regularly thereafter. That care which recognizes and responds to the needs of the human spirit when faced with trauma, ill health, or sadness, and can include the need for meaning, self-worth, to express oneself, for faith, support, perhaps for rites or prayer or sacrament, or simply for a sensitive listener. That is that care, spiritual care. Spiritual care begins with encouraging human contact in compassionate relationship and moves in whatever direction the need is required. That is the national, this is a UK definition of spiritual care. In pediatric studies, spirituality and spiritual well-being are associated with improved coping, coping to chronic or terminal illness. How do they cope with hospitalization? How do they cope with suffering? How do they cope with nighttime fear? How do they cope with disability? So spiritual well-being is associated with how they cope with chronic or terminal illness, hospitalization. And somebody has said in adolescence, spirituality and spiritual well-being are associated with improved coping with chronic illnesses, providing a buffer against developing depression and maladaptive coping strategies. So in adolescence, spiritual well-being is how do they respond and cope with the issues of the disease itself, and how they respond to the disease, emotionally, how they respond to the disease in how it responds to the pain And that is how you can know that the person is spiritually well or not. And the rest, I've given another general statement which I found in somebody's document. In children, those who attended religious services, 18% reported to be happier even when they are sick. And they are able to volunteer even to do something because of the aspect of spirituality. The next slide. What are the barriers that I have experienced to spiritual care provision? What are the barriers? And I know these barriers does affect many, especially those who serve in healthcare setting. When I ask our nurses, when I ask our doctors, when I ask, our caregivers, when I ask our social workers, what is making it hard for them to also provide spiritual care? They say they lack time, they don't have training, they lack the time to do that. They want to have a private place to do it. They lack the capacity to offer spiritual care that is offered by others. The institutions say we have inadequate staffing in the pastoral care office, and some people say that the reason why they are not able to do that is that they need an extra pay for them to do that. And some of them, they say most of the healthcare providers have inadequate training to meet the spiritual needs of patients. So those are the barriers that is affecting spiritual care provision for children. Even in this age when child life skills are needed, part of the reasons why we don't have child life training for those who serve with children is because of part of it is these factors. And in fact, pediatric nurses that I have talked to, I think in Eldoret, continue to indicate that also they lack time to sit with children. They have a lot of work that they are doing. They have rapid shifts. They lack of continuity in spiritual care. And this is also captured by an African writer called Abarenga. Next slide. The reason why I have brought in the aspect of barriers to healthcare, spirituality care by all the staff in a hospital is because palliative care is not something that should be done by one person. It is an interdisciplinary intervention. And so the question that comes always is, what is the role of the other healthcare professionals in providing spiritual care? And I tell people, I think my slide has a problem, but I tell people the rest of the healthcare professionals are generalists, but the chaplain is a specialist. The same way we have a clinical officer and we have a medical officer, but we have a physician specialist. So when it comes to spiritual care, the rest of the team that offer palliative care are generalists in spiritual care provision. So everyone on the team addresses patient suffering and provides support. Clinicians who develop treatment plans evaluate for spiritual distress as part of distress assessment and practice compassionate presence and accompaniment. The chaplain only comes in as a specialist to offer the spiritual intervention, but the rest of the team are generalists. They identify when the patient is in spiritual distress and offer their availability, which is also as a spiritual response, presence, and encouragement that we are together. And sometimes even it includes praying. Yeah? So sometimes I have seen doctors being asked in our wards by a patient, I want you people to pray for me. And we have physicians who do that, they pray. And that shows that palliative care is not only palliative care and spiritual care and palliative care is not the precept of a religious person, a religious chaplain, or it is the work of every team member. Next slide. What is the role of clinicians in generally spiritual care? I have stated them there. Provide compassionate presence, support spiritual resources of strength, incorporate spiritual distress in assessment and treatment or in care plan, and the rest of the reasons. Next slide. What is the role of a spiritual care professional? I think it is known, performing and documenting and a complete spiritual assessment and treatment plan, making recommendations to the clinicians on what they can do to help the patient with spiritual distress, make recommendations for the patient upon discharge, planning, including connecting the patient to a spiritual care professional in skilled care units like hospice or even in the community. Most of the time, what I do when patients are discharged is to talk to their pastor that we have discharged the patient, and so I hand over the patient to him so that he can continue with spiritual care. Next slide. I want to be fast. What about, do we have other spiritual care providers? Yes. We have what we people that we call pastoral counselors, those who offer pastoral counseling. Pastoral counseling is a branch of counseling that integrates spirituality, faith, and theology with psychotherapy to help people seeking assistance with personal faith and family and faith issues. I think this is what I am. If I was not a chaplain, I would be a spiritual care provider, because apart from my training in theology, I also have training in counseling psychology. So I can integrate my theology into my counseling skill and become a pastoral counselor. And then we have people that are called spiritual directors. This is common among faiths like the Catholic Church, and currently the Pentecostal Charismatic churches are having these people who call themselves spiritual directors. Spiritual directors helps patient or children in the process of their counseling to deal with these spiritual things. It can be done by, we have spiritual directors in Buddhist religion, Eastern philosophies, Islamic, and Jewish. But Christianity, it is a growing area that many people are now trying to explore. But it is very useful in a pediatric setting, because it is one way of developing a child to realize the spiritual part of himself, because it incorporates issues like meditation. A child can be told, I want you to close your eyes. I want you to feel what is happening in your body. And then you are able to mention the scriptures that talk to the situation that is going through his life. For example, you can read Psalms 23. The Lord is my shepherd. And then tell the child what the shepherd, who is the shepherd? What does shepherds do? And so tell the child, so the Lord, God is the shepherd. So through the spiritual direction aspect. Next slide. Spiritual needs of seriously ill children. They have the question of meaning and purpose in life. They want to be loved, and they want reassurance of God's love. They want to feel accepted. They want to feel significant and worthy. They want hope, that there is hope in their suffering. They want their questions answered. They need support and care, help with their fears. Next slide. How many minutes do I still have? How many minutes? You are done?
No, we have 10 more minutes for you.
10 more minutes.
Yes.
So how do you know that a child is having a spiritual problem in a medical setting, or when he's struggling with issues of chronic conditions, despair and hopelessness? And this always comes in form of questions. Will I survive? I don't feel like this thing is going to change. Despair and hopelessness. Refusal to take medication and eat food. Some of them ask, does God love me? They begin first of all maybe by saying, Mom, do you love me? Or Father, Daddy, do you love me? So doubting God's love. Sadness, desire to die, withdrawal and lack of interest in life, worries and fears of dying and death, suspicion and mistrust in people, anger, irritability, crying, disruptiveness, and the overdependence acts loss of self-worth. Next slide. Arising questions by children facing life-limiting illness for parents, for patients, and families. This is general. Why me now? Why, what, who has caused this? Children ask the same question, especially when dealing with end of life. Why was I placed on earth? Is there hope? Why do I have to suffer? Is it okay to say goodbye? I have not found the one telling me, is it okay to say goodbye? But the questions like, is there God? What happens after death? Those are questions that they ask. The next slide. I want us to go to the next slide. This spiritual assessment in children. The next slide. Spiritual assessment tools. There are several tools. There is what is called the HOPE tool. The HOPE tool is based on the acronym HOPE. H is for sources of hope. O is for organized religion. What is, does he have? Does he go to church? Which church? P is personal spirituality and practices. What do you like to do when you are in church? And E is effects of medical care and end of life issues. How do you feel right now in your body? Where do you have the pain? Do you feel like you still have the strength? So HOPE tool. And then there is an open invite mnemonic tool. Open means open door for connection, conversation. May I ask you about your faith? Invite is invite the patient to discuss spiritual needs. And then we have the faith tool. F is for faith, A is for apply. What about faith and health? I is for involvement in the church. Are you involved in a church? Do you go to Sunday school? Those questions. T is treatment. Does your spiritual views affect, framing it to a child? And then H is help. And then there is what is called the spirit tool. It's also an acronym. But for me, I use the final one, the Kehpca tool. The Kehpca tool is what I use for taking spiritual history, and it is recommended for even clinicians and everybody. It was developed by somebody who taught me palliative care, Dr. Buchaski, and a group of primary care physicians in America. F is for faith and belief. I is for importance, community, address how to address care. Next slide. The next slide is an explanation of the Kehpca tool, faith and belief. Do you consider yourself spiritual or religious? For a child, if you tell them spiritual or religious, they cannot understand. So you will ask, beginning from the typical question, like, where does your parents go to church? Do you also accompany them? What do you like in church? Some of them will tell you, I like praying, closing eyes, and you will locate whether he's spiritual or religious based on how he expresses, how they express their faith in their denomination or where they go to church. The next slide. Importance. The next I. Kehpca. F-I. What importance does spirituality have in your life? Why is it important for you to go to church? Why is it important for you to pray? Why is it important for you to sing? Those questions. Next slide. Community. Are you part? Now you will already have the answer to this because for a child you have to begin from what he knows. And then next slide, A. Address in care. How would you want me or your healthcare provider to address these issues in your healthcare? The issues that come up out of that tool. And then the next, wow. Next, again, I think this one I've mentioned, spiritual care. How do we provide this spiritual care intervention? Provide a secure and caring environment. Listen a lot, deep listening. Reassure and maintain hope, allowing expression of personal beliefs and values. Provide religious and sacramental care according to individual denomination, faith, affiliation, or faith tradition, I think so. Don't be judgmental. Most of the time, you find people who do, like recently, somebody came and asked me, why are people praying to Mary? And I asked the person, why are you asking that question? I saw somebody praying to a child in one of the wards, and the person was talking about Mary, the mother of Jesus. And because we were in a space that was not in the word, I told the person, that is a practice. That is part of a religious tradition that child subscribed to. And maybe he can really understand Jesus better because he can associate Jesus with his mother or her mother, like the way Jesus is associated to Mary. So I told the person, we shouldn't be judgmental on other people's faith. Next slide. Why importance of spiritual care? I think I've mentioned it, a few of them previously. Culture and religious consideration. This is what I want to talk. I have mentioned it, but I want us to really think about this. We live in a multicultural society. Many people assume that children are cultureless. They are wrong. Children have a culture. They have a culture of their home. They have a culture of their environment, especially children who come from a place that is not multi-ethnic. They have been brought up, socialized into their environment. So they have a pattern of doing things. They have a culture. I call it patterning. And so when handling them, we need to know the views of death and illness in that culture, to know their social custom, to know the relationships that he or she has, so that we are able to help them in their decision making. So the cultural care strategy: identify cultural beliefs, understand and respect all cultural values, and so that you are able to have effective communication and avoid conclusion based on limited information. So when you understand somebody's culture, that is how you are able to reach to them. In fact, what is needed in a medical space, I have recommended most of the time, is for everybody to have intercultural skills so that we are able to meet the needs, the contextual needs of the people we serve based on their realities. The word of God is universal, but it has to be applied appropriately to every context, to every person in his contextual realities. Thank you. Next slide, which is the final one actually. Because I have been very fast, let me relax a little bit, ask for 2 more minutes. And let's see this case. A child with hypersplenism and recurrent anemia for 5 years was admitted. The mother and other church members who came declined blood transfusion despite intensive counseling and consultation. And the child at the point of death was not able to make any decision. Previously, the mother had lost 2 children due to anemia. And even at that time, she is not willing to change her mind. What would you do to deal with this? First of all, you have to identify the religious background before you think of the solutions. So can we have a discussion? I don't know if we still have time, but this is the last slide. I've said a lot of things, but very quickly, but this is a case that happened somewhere. You are supposed to do.
Anyone with any ideas, you can raise your hand or put it in the chat box.
Are there responses? I'm not seeing any responses. Okay. One, this mother and the church members. Okay. Sorry.
Thank you, Reverend, for the great presentation. And I'm just thinking, based on this case, one, it's a very difficult case. And I am waiting or listening to hear how did you handle it? Maybe before then, in-depth talk about the different specifics in terms of disease, the expectations from all the sides, and being sure that the mother understands from our point of perspective, and also us understanding her point of view is key. But I'm not so sure it's easy to deal with this. Thanks.
Okay, one thing that we do in living room is what we call family meetings. Once a patient is admitted, let's say this evening, the first thing we will do tomorrow is to have a family meeting. And in that family meeting, we begin from what the family knows and the decision maker. Sometimes the decision maker, part of the decision making people, we have maybe a church, somebody from the church that the family comes from, and the family allows us to have one of them come. So when this case comes up, what we did was to have a family meeting and explain and learn from the family what they know. And then after they said that the same condition that this child is having is like another condition, a similar condition affected 2 other children from this family. And so that was already a red flag that they have been struggling with this aspect of medical problem. But when they went to the hospital the first time, the other time they didn't accept, they declined blood transfusion. So that is what we determined first in the family meeting. And then our medical officer or the physician discusses the importance of blood transfusion. But in the process, I realized that there was a religious issue here. And I interjected and asked the question, where do you go to church? They told me, one of them said, we go to the Kingdom Hall. And so immediately in my mind, I knew this was Jehovah's Witness. And it is part of their faith, their belief that when one is sick, is not supposed to have blood transfusion. And so I knew we were getting into a more difficult problem. And so good enough, we made a lot of progress. But in the process of getting an agreement, we lost the child before we had finally come through in our discussion. So you see, I wanted to bring this case to demonstrate that religion, spirituality also affects care. And if in places where there is no such intervention, it is possible not to get for the children not to get the right care. And many children have been lost because people didn't understand the background of the people they were dealing with. That is the summary. Thank you. I hope I was useful. Asanteni. This is the conclusion. Asanteni. I'm done.
Thank you so much, Reverend. Yes, you were extremely helpful. In fact, I think there are so many questions you need to answer. In response to that case, I've seen some replies. Someone suggested to explore and find out about her beliefs. That was Faith Gatiaga. Eugene.
Okay.
Eugene says, I guess the mother has autonomy over the child in decision making, but recurrent discussions in family meetings is necessary for decision making.
Let me say something about that. Yeah, if the child is not able to make a decision, yes, the mother can make the decision on his behalf. But in palliative care, we try as much as possible to explain things to children, especially those who are able to make decisions, so that they are able to make the decisions themselves. Otherwise, most of the time, many children suffer because even at the point where they are able to make decisions, the hospital tends to leave parents make decisions on behalf of their children. There are levels of growth, development in the capacity of the child that we need to remove the parents' autonomy over the autonomy of the child.
Okay, thank you so much, Reverend, for that. I think it brings up another question that was asked about balancing the needs of the child versus the needs of their caretaker, if they're different. Maybe I can ask a question. At what age is a child able to express their religious or spiritual needs, Reverend?
I wish we would go back to the slides, but no, since we cannot go back. Nowadays, at the age of between 9 and 12, many children are able to understand many things. If people take time and explain the condition progressively, I think many children are able to understand what is going on. They are able to have a discussion, even when there is interventions, procedures to be done. You cannot take a child to a surgical theater without explaining what they are going to do first. Otherwise, you might end up having the child crying to the point of not even going through the surgical procedure. So I think it is up to the clinician, the mother, and the hospital resources that are available to determine whether the child is able to understand what is going on or not. But what all the time I tell people that I do not subscribe to the fact that children should be taken like sheep for slaughter without their consent if they are able to consent.
Okay, thank you. Another question that was asked earlier is how can children differentiate, or can they differentiate between spirituality and religion?
No. It is. What did we say religion is? You know, sometimes you are not able to. Religion is organized, and most of the time people say religion is what we actually received, but spirituality is a way of life, and already in African culture, we are spiritual because in African culture, in everything we do, God is there, and we would want to know what God is saying. So when we embrace Christianity, we embraced organized religion and organized faith. So we exercise our spirituality within that organized faith. In fact, in our context, we have very few people who don't go to church. Most of us are either religious by association, and we exercise our response to the transcendent through our attendance of our organized religion. So children are part of this. If the family is just religious, those who are associated to a denomination, let's say Anglican, the children will experience God through Anglicanism.
Okay, thank you so much, Reverend. Maybe we can take a few minutes. We can extend the webinar by maybe 10 minutes. There are still several questions that were asked before we began as we were waiting, as well as I'm seeing some raised hands. Maybe we can take some questions from the raised hands and then we get back to the previous questions. Go ahead, Marculin. Can we get Marculin to please speak?
Dr. Remember, they are enabled to speak. They can unmute.
Oh, okay. In the meantime, maybe let me ask some of the questions we had earlier. Someone asked, what do you tell a child when the child asks, Daktari, why is God allowing me to suffer? And maybe it'll go together with another question. Someone else asked, what do you tell the child when they ask you, when do you think I will die?
Musyoki is there. He can try. He can help me answer some of these questions.
I am not so sure I could match up, but sorry, come again, Dr. Weremba. Which question was that?
One was when a child asks, why is God allowing me to suffer in this pain? And the other question was a child asking, when do you think I will die?
Let me attempt, and then Reverend will definitely confirm or take us to the right direction. Many times, and based on literature, when people ask these difficult questions, most of the time, it's not like they want us to give definitive answers, but from palliative care perspective, they are in distress. They are expressing suffering, and they would wish someone to listen and to listen to their pain. And it's because when they do so and they ask, it's a sign of distress. And therefore, these difficult questions, most of the time, we do not have answers and we are not able to answer. And even if we try to answer, we're not so sure that those answers are correct. And we can't be God to give responses about Him or the Supreme Being. And so my response around why is God allowing me to suffer or punishing me, you would want to hear more and probably toss the question in a mindful way to them. Why do you ask such a question? Asking a question on top of a question so that you hear more and probably want to see what are the issues behind that question. What are the fears? And then probably make a commitment from a spirituality support aspect that we will be able to support or provide the unconditional presence and address the physical issues that they have. And where we are not able to provide that care, we say we will be here, and with honesty that sometimes it's good to say we don't know. Thank you.
Yeah, I like the response, the answer, and I knew that you will answer it. In palliative care, we need to avoid creating distress on top of distress. The question about suffering and whether God is there is a sign that the person is dealing with issues of meaning and purpose. If a pastor or a spiritual care practitioner approaches it as a discussion of theology, then it will create more distress. So in a palliative care setting, when dealing with issues of life-threatening illnesses or chronic illnesses, the response always is getting a solution to the bigger challenge, spiritual distress. And that, as he has ably stated what is needed: presence, accompanying. In fact, you lost me. In fact, the best way is to have a story. And the story that I've been using is asking them whether they have heard about Jesus going to the cross. And I asked them, when Jesus was going to the cross, how many people were with him? And most of the time, children, because of theory, they will say there were soldiers who were beating him. Some of them will say, but there came a person that helped him carry the cross. Sometimes they say even his mother was there, Mary, and other women. They can recall a few things. Those children who have had an experience to go to Sunday school or to go through CRE, they'll always help you. And that is one way of allowing them understand that suffering is part of what will happen in life. And most of the time, after we have finished the story, they will say, so Jesus is with me and has given you the opportunity to be part of those who accompany me during this period of pain. Asante. So have stories around those things, but don't get into the argument of, oh, there is the fall, Adam fell to sin. Because of Adam fell to sin, we are now suffering. Now they'll say, why should I suffer? Because of Adam's sin. You know, you get yourself into a lot of discussion. Asante.
Thank you for those answers. I think that also answers the question of how to explain to a dying child that God heals when he hasn't healed me. We had another question about someone having the experience of a child having the desire to die, especially a teen. The person who asked the question posed that, is it a way of coping in hope?
It is still a sign of spiritual distress, hopelessness. And if and if that person is a teen, I think I gave a statement on adolescents, and I said the highest percentage of those who have been polled or researched, most of them respond very well with the religious answers. You know, death is a loss. When the teenager is struggling with pain, he's already dealing with the loss of not having his or her life as it has been. But now he's looking for another loss. And hopelessness needs a solution, a future solution. And I think even for Muslims, even though they resign to fate, they still talk of paradise. They still talk of life after death. Life after death. So and I think that is when now, for a teenager, you need to discuss what is accomplished at death and what happens after death, because they are able to understand. And most of the time they get the joy and the peace that they need as they go through the dying process. So hope, what the Bible offers us, hope. And the other aspect of parents saying, we love you and we will allow you to go and be with God.
Okay, thank you for that. I think the general message is to be there for the child and to offer hope and to ensure that they understand that their life is not without meaning or purpose. Judith, I see your hand is raised. Samuel, your hand is also raised. Maybe as they prepare to. Oh, sorry, go ahead.
Yeah, so thank you so much for the opportunity, and also thank you so much, Reverend, for that comprehensive presentation. I really have a concern on the kid who died, the story that you just displayed. It's so unfortunate that it can go that extreme due to some religious beliefs. I wanted like clarity like on the balance between spirituality and the ethical or the legal issues in dealing with some of these issues. Um, if we look at the Kenyan Constitution, it says like the Constitution is the supreme law of the land, and everything vests in that law in the Constitution. And in the same Constitution, if you look at Article 43, 1A, gives every citizen a right to healthcare services, and therefore even children are part of that. Uh, could it have been better or appropriate to then apply this so that the life of the kid could be saved? The international law for children's rights also give children the right to access to health care. And so could it be appropriate to maybe, as an institution, give the child the care so that the life is saved irrespective of the refusal by the mother? And also on the religious aspect, why do we still allow some of the churches with extreme I don't know how to describe how best to describe it, but that I feel like it was very extreme to believe like transfusion should not be given to someone, should not be done to someone. Why do we still allow such kind of churches to exist? Thank you.
Is it me to answer?
Yes,
Yes,
please.
please. Yes, please.
Yeah, the case in point is that this is happening within a few hours. So, but finally, one thing that we do finally is actually to use the government to enforce some of this, like the way once in a while there are those people who refuse to take medicine, like the tuberculosis, and they are finally the government uses the resources they have to make sure that they do take. So, but the case I brought was, something that just happened. And one thing that I've realized as a palliative care hospital, most of the time we get patients that come from government hospitals that the doctors and the rest of the healthcare teams have given up on them. These religious things are a reality. Yeah? I was told by another person there was the Mombasa issue also in Eldoret, and a lady appeared who was not eating. And even when they are forced to eat food, she waits when you are gone, they vomit, they force to vomit. So the case that we had about the child was just, it's a case that happened within a few hours because already the child was, anemic, and yeah, he had lost a lot of blood. in the course of treatment and we coming up with interventions on what they're supposed to do, blood donation, looking for blood, we lost the child. So, but I agree with you that policy implementers in this country have failed us because we have a lot of religious movement that nobody scrutinizes what they believe, what they do. We only wait for when the problem comes, that is when we respond. But that is our country. Yeah, it's our country. And all these institutions that we serve, we end up getting those challenges and realize that we have lost this child, and yet we would not have actually lost that child because access to health should be mandatory and should be something that goes beyond culture, goes beyond religion, because it's about life. And even the same Bible talks about the value of life, which sometimes is lost because of extreme religious beliefs. And that is why I'm saying in palliative care, we should be cautious as medical healthcare providers that we identify those things that hinder the provision of care so that we are able to intervene at the right time, respond to those issues in the process of we supporting those that we serve. Thank you.
Okay, thank you so much, Reverend. Thank you for the great presentation. There have been several messages on the chat saying it was a great presentation. I think we really learned a lot. Maybe we can have you in the future and do some case studies because a lot of the questions seem to come from personal experience. But thank you so much. We were honored to have you. I believe you've given us some valuable knowledge. As generalists, we look forward to engaging the specialists. Thank you so much. Yeah, we look forward to having you back.
Yeah, let me say thank you also. I'm sorry I was late. It's like I feel like I didn't exhaust what I was supposed to say, but thank you for the wonderful comments. I'm just reading the chat. God bless you.
Thank you. It was so informative.
Yeah.
Yeah, I'm sure a lot of
face to face.
Yeah, we can organize something for sure. Yeah. Thank you. I'm sure we had a new different approach to spiritual matters. Okay, with that, I think we can call it a wrap with today's webinar. Thank you so much, everyone, for showing up. Thank you for being patient. Of course, there are always challenges when trying to organize some of these things. We hope everyone got some kind of information or knowledge that they can apply. And if you have any questions, please forward them to Kehpca and we'll see how to answer them. Thank you, everyone. Have a great evening.
God bless you.
God bless you too.
Thank you. Thank you so much. Thank you, Doc and Rev.
Welcome.
Thank you. Good night.